All right, senses. The fluid and electrolyte balance is nothing more for us at this point would be if you're dehydrated. I don't see anybody in fluid overload here, so we would think you're not drinking enough, you know, something like that. And the neurological, which ties into the senses, but we do not really focus on that until 105. Yeah.
Professor Upshaw, we just mentioned, I believe, 8 hormones with is that all under modes?
The modes are 4.
Okay.
There are 4, but we're only focusing on the physiological. In the physiological, we have oxygen, elimination, you know, the categories that kind of fit the human being and where problems can exist. Whether it be your problem or as you go to the hospital, you're going to see problems there. And then the other one, the last of the physiological mode, according to Roy, is endocrine. And that would be when we have the first semester in 105, and that's diabetes or thyroid. So, how, I'm just going to give you some questions for like the patient here. What you need to know is the most important things.
I don't think so.
Because we talked about how these patients can have multiple problems. And this is your problem, right? So you think about it. And how are you going to write it? All right, you look for the nursing diagnosis first. Can I just finish this or no? Okay. Is it? Oh, okay.
What is the difference between simile and focal? Because I know that.
Okay, well that's coming up. Because we talked about adaptation. How is the patient adapted, right? And according to the terminology that you may see in your book, the small one, or if you've got the big Roy book, you'll see that it's an adaptation level. So depending on the condition of your self-diagnosis, you would either be keeping it together, which is considered integrating, or compensating or compensatory, which just means you're still not quite there as far as, you know, dealing with the lack of sleep, but you sleep on the weekends, okay? So that's kind of like, I would think of if you had a diagnosis of, you know, lacking of sleep, which would be underneath the activity and rest, right? So, but you are compromised is more of a big diagnosis.
Maria.
Meaning they're totally shutting down, you passed out, you're not breathing or something, or, you know, you have an accident, something like that. It's going to be like the ranges is the person is able to deal with it and maybe just a risk for it. Then they are compensatory, which means they sleep on the weekends. They've got a way around trying to keep their sleep, you know, in a more normal fashion. And then if it's compromised, you're having more significant problems, all right? So it's just like a range of how you want to deal with it or see it or put it in a box of diagnosis. So you have this diagnosis for whatever is pertinent to you. What's causing it? That's your stimuli. Obviously, you've heard that word before, right? What's causing it? So when you break it down to what's causing it, Sister Calista Roy has 3 categories. The first one is focal. What's the main, think about like the focus of the lecture, the focal point, that's the center. What's the big thing that's causing this, okay? It would probably, if it's lacking enough sleep, it's nursing school. Okay, but I keep throwing this in so you kind of make it more real. All right. So in the PowerPoint I would have shown you is the focal is the major influencing factor. Then there's the secondary kind of problems, and her language is contextual. You want to put contextual, secondary, that might help trigger your mind. It's contributing to the problem. So if you, I'm gonna use the sleep all the way through, guys, okay? So the sleep, a contextual problem with the sleep. So you've already decided that it's all about nursing school and you're just like worried sick. So you also would say stress level and nursing school is probably focal. Contextual would be something like there's a dog party, there's you know, the partiers next door, whoop, 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 all night, okay? Or you're stressed because you didn't have your books, or whatever fits you. That would be the things that are common, or I have to work an extra shift, those kinds of things. The things that are contributing to make this nursing diagnosis on yourself more real. And then the last one, and I don't know why y'all have a little trouble about this, residual. What does that word mean to you?
Ongoing, adding up.
Adding up, residual. Like if we say, all right, the patient has some residual stiffness in the right leg from that fracture and having had that cast on not just 8 weeks, but 10 weeks. Okay? So it's like a hunch, all right? It's like you can't specifically say, well, I'm not sleeping because, you know, I drink too much coffee. That would be a hunch, you know, like when you're with your patient. I mean, obviously, your hunch is you already know because the care plan's on you, okay? But a hunch is something that you cannot exactly say, yeah, that's causing it. Something very common that happens to fall into the residual with your patients in the hospital might be culture, age, a hunch of maybe 20 years of smoking has caused the COPD, but it may not be considered residual. It might move up if it's really linked. Okay, so everything matters. What's causing it? What you think is causing it? Or the contributing factors that it's causing this problem. Let me just finish this next statement, because I love answering questions, but I'll trace off. I don't want to trace off at this moment. So then, what you have is you're looking at the stimulus, you're seeing those behaviors. What are the behaviors that that student is demonstrating that show the lack of sleep? So you might document puffy eyes, irritability, just, you know, making it worse with biting their nails or toenails. Somebody did that. You know, whatever is that underlying behavior that tells you this is a problem. Then you're going to realize what is causing it, and your goal would be short and sweet, short term of patient. It's got to be connected to the behaviors, to the problem. Patient will go to bed at 8 o'clock every Thursday starting today. You know, it's a today thing or short term, very measurable for you, right? And or student will, for a long term, will make a calendar with the different activities and naps by the end of the month. It's not a big deal, it's very simple. You keep it simple, and then that way you are dealing with the behaviors, which is really kind of what you're seeing in clinical, or within yourself, you're assessing. The second thing would be the stimulus, what you think is causing it, focal, contextual, or residual. And now you want to make sure that you have a diagnosis that fits this behavior. So if you look on your little magic sheet, well, your nursing diagnosis book or what have you. Oh, what is this thing? So I can look right there. Ran out of my help at the meeting. All right, so here's my little trustee thing. And they have it listed, so these are listed as hygiene problems, neurosensory. And you just look in your book, dial-up diagnosis. This one here is fatigue. There's one here for rest and activity. Fatigue related to what? Lack of sleep, nursing school, and long hours of work. So it's always a three-part. You state the problem, you stay at related to. Yes. You want to make sure that your diagnosis that you make, however brief you make it, is going to be manipulating the stimulus that's causing that. So just make sure it all relates. It should be, well, I shouldn't say that. I've been eating and sleeping this for a long time, and I'm trying to make sure you understand that it's not rocket science. It's basically trigger it back to where the behaviors are and make that better if you can. Or if it's not a problem, it's an at-risk question. Yeah. Yeah. You mean on the board right now? Oh, sure. Or I have some samples I can send around too, but then that'll take you away. So let's do it. I'm not like my wonderful memory. There's something about it just. Yeah. Sorry?
In regards to residual, would type A personality be a residual?
Sure could.
Perfect.
Or a better, some other kind of narcolepsy. All right, so.
And now you're like, yeah.
Well, it actually has insomnia as one of the diagnoses, but it sounds like sleep deprivation. Are we there yet?
Yeah.
Alright, so it's not very dark to start with. Sleep. We all get what you get. I went, oh, there's 4 colors.
It's terrible.
All right.
It's
Go. Better. Related to. That's no. I'm sorry. I can't eat you.
Is it capital or is it small?
Doesn't matter.
Okay.
Oh my gosh, Trivial Pursuit. Oh. Write it so I can read it.
No, I got it.
Related to is an actual problem. Okay? So you really want to have an actual problem as evidence-based, as evidence by, do it this way, as evidence by irritability. Irritability. Can you?
No.
R.
Oh yeah, there's two.
No, it's T.
Well,
There's a T before the A.
yeah. Okay. See, if I do it over here, I'm okay. But if I do it up there, I don't. And I've been what do you call those people?
It's like too close.
Author that checks stuff out. All right, but I can't do this every note. So sleep as evidenced by irritability, sleeping. Okay, that sounds okay. 3 hours per night. Okay, that's pretty measurable. So, sleep deprivation related to Yeah,
It's healing.
related to, and you can put all of that in, nursing school, if that's what you want to. Is this your, the behavior, it's not exactly behavior, so related to nursing school or type A, type A, or, because you have to make it work with the person. So sleep deprivation related to nursing school, 3 jobs, that's me, 3 jobs, what else? Oh, a sick child, you know, ongoing, sick child. I had a lot of, sick children. As evidenced by irritability, lack of only sleeping 3 hours per night. Okay, so what kind of goal would you want to do for somebody like this?
Get more sleep. Get more sleep,
That's a good one. So, how about, I'll just write patient. So the patient will make school calendar. By the end of the day. So that's one short-term goal. You get it?
And then you said, once again, if it was on a hospital time, it would be patient will, long-term goal will be before discharge. Got it.
And yours would be before the first test. No. More sleep. I always want, you always want to use your own calendar. All right, now, we've got a problem. We're not sleeping well. We know what the behaviors are. And we have a goal. So what would be some of your interventions?
I just had a question. What would be the residual in that scenario?
You could have age or culture, like if you were Jewish. And, you know, I mean, you know, I'm looking through some of the other patients and students that have done this before. Distraction,
Red Bull.
overload.
Could it be lack of organization?
Yeah, well, that's what he was saying, time management. So maybe that would be my long-term goal. Go attend time management seminar, or we used to have a tutor here that was wonderful. That's all she did was help students get organized. Because there's so many things coming at you in first semester that is foreign.
So it could basically be anything that you have a hunch as a nurse as to why
Oh, absolutely.
it's not occurring. It's not like there's a specific, you know how nursing diagnosis, you have to follow nursing diagnosis. It has to be on the chart, something that's,
Well, I like you to stay there in the beginning.
but not for residual. Only for nursing diagnosis.
Well, I like you to just try to follow the format. You know, I mean, if you go ahead and deviate off, you know, and then we can talk about it. It may be real, it may not be. So now we're out with the sleep diagnosis and the outcomes. So what are you going to do to make this better? What are your interventions? Better sleeping schedule, less coffee, nutrition, exactly, that was another one I was gonna say.
No partying.
You know what?
No partying.
No, I won't say that. But I mean, I'm trying to make it as simple as it can be. And like, let me give you another example of somebody else. Now, this is an actual patient. And this is my student from 2008. I know she's already causing troubles now. Anyway, so here's a kind of a real good example of how she turned this in, and this is what the scenario is. So you kind of get a sense of this when you're in the hospital. I usually have to do this thing on your own because it kind of helps you figure out what the pieces are, okay? this is a 77-year-old male. Medical surgical diagnosis is the next column down. It's pneumonia, bronchial asthma, seizure disorder, progressive dementia. Sounds familiar. History, she wrote, and you would have a head to toe already done. And as you can see the head to toe and see what's adaptive and what's not adaptive in those modules like oxygen, whatever is called, can relate here. But I'm just giving you all these medical terms that she went ahead and put it on here because she didn't turn in on. I didn't have them turn in a head to toe so I could see where they were going with it. So here's the history. Hypertension, benign prostatic hypertrophy, cardiac arrhythmia, chest x-ray reveals lower left lobe infiltrate, which is up in the lung. Air entry is poor. Now that's not very specific enough for me, but she could say air in shallow breathing. That's something she diagnosed as she was doing her head to toe. So that she put air entry is poor. I knew she knew better. Lung expansion is equal, but bilateral bronchi. So that's like noisy lungs because of the inflammation in the lung tissue. You can actually hear that. We'll get there in oxygenation. But if you don't know where it's the name of that particular cell is oxygen, even after you do oxygenation, you could always write something very benign like adventitious lung sounds. Okay? Anyway, that's what she's diagnosed, with bilateral bronchi. Client shows shortness of breath, labored breathing, and it said he lives at home, unable to give information due to the progression of dementia. So that's okay. But I would have definitely, as my correction, I have said, I want to hear the respiratory, the respiratory rate. I want to know the O2 stats. Let's have some, meat on this bone, so to speak. And is the saturation on RA, room air, or is he already getting supplemental oxygen? You want to paint a picture here. Only one problem though. Don't get cuckoo. All right? So she said she's described the behaviors here, and then she also put in unable to follow command, mechanical soft diet, on O2 2 liters as ordered, Foley catheter in place. And you've got to get an idea this patient is interactive. Mechanical soft diet, older, it's not able to choose, swallow the lung, drink enough, So anyway, her focal is impaired gas exchange related to pneumonia and bronchial asthma as evidenced by labored breathing. And then I'll look up that respiration rate. Contextual. Now, she thought the contextual was due to his age. So maybe he's an old 77, because I've seen some 77s that are just like, okay. So anyway, she put age in here. She put being 77 years old. That's the same thing as age. All right. With poor ventilation system, which leads to infection, and I wrote in here, and morbidity. Okay. Residual, poor nutrition, because he's got some chocolate diet. May have smoked. She doesn't know it's a hunch, but it's maybe in the chart somewhere, but that's its own assessment. Dementia, I like, hello, this guy's demented. Supposedly he doesn't follow command. So when you ask him to do the breathing exercises, or whatever it might be, he's not going to follow or be compliant. So her, again, the diagnosis is impaired gas exchange related to decreased functional ability of lung tissue. That's kind of where you go. Evidenced by pneumonia and bronchial asthma, and she should have more, data here as, the lungs sound like bronchi or whatever you might hear. You want to see as evidence by which is assessed bronchial noise, inability to participate. Well, that would be pretty much of it. You see what I'm saying? You get it? Okay. Short-term goal. Patient will demonstrate improved ventilation and adequate oxygenation. So it's a short-term. Patient will demonstrate improved ventilation and adequate oxygenation by improved respiratory rate and, hold the door. Improved respiratory rate by the end of the day. What else? Client will maintain clear lung fields and remain free of signs and symptoms of respiratory distress by the end of 3 days. I think that's reasonable. I think so.
3 days.
3 days? Antibiotics, probably triple antibiotics, depending on the doctor and the other situation and how bad is it. Actually, I've seen it where the patient comes in with pneumonia, the same age bracket, they get put on double antibiotics. From the culture, but still, they're on double antibiotics and they're out the door in 3 days. Because you can take it, they'll convert it to by mouth antibiotics and get it home or to the skilled facility. So that is reasonable. So, what are her interventions? Deliver 2 liters of oxygen, normal, as ordered by the physician. Monitor the O2 saturation continuously. Observe for any changes in skin cyanosis. Position the client in a semi-Fowler's position with upright posture, if possible. And some of the other interventions I would do would be breathing exercises every 4 hours as tolerated. Utilize the oxygenation as ordered, but then I would do some, I would do some activities without the oxygen. Let's just see what he really is, where is he really saturating at. Continue antibiotics as ordered. So which continue antibiotics as ordered? What kind of intervention is that? No, collaborative. Think about, you can't go around giving antibiotics. You want to practice medicine? It's called collaborative. So you can see these interventions. What we like to see, I know Sheila Catalano is one of our clinical instructors. She is like the queen of this stuff. I actually want her to come in and go for it because she's very, but anyway, she wants all the nursing interventions first because those are the things you can do. Positioning, raise the head, position of comfort, teaching, things that you can do. And then let's bring in the collaborative help, or dependent help. You'll find terminology anyway, where you're going to say, deliver breathing treatments as per order, and make sure he's getting medication on time, practice with incentive spirometer, or do breathing exercises, whatever works, okay? And then the evaluation here was the patient's blood gas level was within normal limits, and that's technical, but patient maintains clear lung fields and remain free of respiratory distress. It still works. I wasn't there, I can't tell you. So this is all I want from you guys at this point. As we go along, it's going to get bigger because you're going to have nursing diagnoses. You're going to be writing out the pathology. Why is this even happening? You can get it from your book. So when it says citation, where is that from? So,
So if the patient that has dementia, somebody that's not gonna be able to obviously always corroborate with you, you can't really get them to do this barometer. You can attempt to, but it comes down to their cooperation.
right.
So you're really kind of limited to kind of making sure the meds are given at a specific time, making sure that the patient's bed is elevated so that their oxygen level, you know, you're kind of
Well, I
just
would do-
maintaining it, right?
Yeah, if you won't follow instructions with me instead of barometer, I might, you know, do some breathing exercises where I ask you to inhale, blow, you know, they're actually good patients.
Sometimes, right, it just depends on
It
the
just-
person.
yeah,
It just depends on the
exactly.
person.
So, and then getting him out of bed, turning, cough, deep breathing, that's the lingo. Turn, cough, deep breathing. Yes.
At what point in time does respiratory or OC, PT become involved in this?
Well, the doctor's gonna order respiratory, all right? And if he's,
And I, as a nurse, can advocate for that, for instance.
oh yeah, I always tell him to do it.
Okay.
You know, it's my patient, you know, you gotta get, at a certain point, you own the patient.
Right. So my question was, and I forgot to make point. So we'll join the city. Who does the respiratory treatment?
It's written in a chart,
It's us.
it's there, and it's written so many times per hour. It's very clear what drugs they're giving. And if I come in at 7 o'clock and your patient has all that ordered and they haven't come to do that respiratory treatment, I'm calling. And then when you're in clinical, I really, this is like going to happen for sure. You're going to have this kind of a patient. I want you to do your assessment, listen to all the lung fields, and we'll be getting into that next week, before and after the breathing treatment. It's a miracle how much better it sounds. And then there are also different ways we can move the secretions up to the lobes up here, and then your lung sounds will be different. It'll be more tracheal, like moisture rather than that curl down the barrel of the lung stuff. So let's just do a little exercise.
So I have a question.
Okay.
So you want to do this care plan for about ourselves?
Yeah. Pick anything you want.
Not just create the patient.
No.
Okay.
Someone did that a couple years ago, and they got so caught up with the book. And I'm like, no, it's more real for you the first time. You get a lot of this in clinical. But I just wanted to give you a heads up. Try to go through the process, because knowing nursing process, which is a care plan, assessment, you know, diagnosis, planning.
Implementation.
Yeah, that's what we just talked about. All right? Yes.
One more. I just want
I don't
to
care. I'd rather you ask me questions.
So,
I do not want
it is just one problem of us?
Sorry?
It's just one problem of us, or we can have several?
For our intensive.
I mean the care
purposes.
plan, just we are.
One problem,
Okay.
one care plan. As you go along, you will do more, but we, you know, first semester, even next 105, we want a well-written care plan with one physiological problem. And when we say the concept map that we do, it's really more about the etiology. What are the, you know, this is like you're telling us you've read the book and you understand how the lungs work and the etiology of pneumonia. What did you see? Well, how did you get to that diagnosis? And you want to make sure that your assessment matches the diagnosis. And then, like, these things just help you know more about the medicine. Or people that do concept maps, I mean, you're going to be doing this, they learn by concept mapping. Because they'll put the patient in the middle and they'll do this, or the problem that you're seeing in your patient with the clinical manifestations, your assessment, And this teaching and all that comes later, but what are you gonna do? How are you gonna know it happens? Diagnostic tests, clinical manifestations, or you could call it behavior stimuli. You know, everybody has like a little, you know, word, but it's all the same. Yes?
For evaluation, what do you say we're supposed to put in there?
If you have met your goal for your patient and or you're sleeping better, within 1 month, student has acclimated to the insanity of nursing school and is sleeping more restful,
It can be long time or short time.
whatever you want. If you have not met your goal in the real thing or in your care plan, you would write, you know, not, you know, evaluation, patient unable to reach this goal, whatever it may be, and that would mean that at that point, in that part of the nursing process, you go back, reassess, and either change the diagnosis or add some different interventions to make it possibly easier for them, for you or for the patient to get to that goal, or if it's resolved, that's it. Patient's sleeping patterns have been improved, whatever. Does that make sense? I still think you're a little lost. I really do. It's bigger than all of us, this nursing process. And that's why well, this is a concept map. It just depends on what you're doing. I only want you to do the one written care plan, the 1 page, and then we'll work in groups and go through it, okay? Because practice, the concept mapping we'll go through next week or the week after that, because every single class, not only nursing, but every college district, every university, we have to prove that we have met the nursing objectives, or they call it student learning outcomes. Okay, your student learning outcome for 104 is to create 1 care plan and 1 concept map, which is due in like what, week 7, and just a way, I collected, your clinical instructor would be the one that would be going through it with you, but I just collected at the end of the 104 time because I need to know, are you meeting the objective of this student learning outcome, all right? And that's how every nursing class is set up at any university, at any place, because this is what we are. We're nursing process, all right? You might have a different theorist instead of Roy, and there might be slightly different lingo, and when you do your ratios, you'll find that out. But for us, right now, it's Roy, and I might upload, I'm just like this, I'm bigger than life, so I fly around. So, if that, you have a PowerPoint that tells you everything about Roy, but I didn't get to listen to the rest of that YouTube thing, but it was pretty good. So if it's really good and it's valuable, I'll post it. You know, so you can, our good friend, Sister Melissa Roy.
With the evaluation, with the evaluation, you said patient sleeping patterns have improved. Do you want us to, side note, make why we would make that statement? Like,
Yeah, if you want
we
to.
have to.
To me, in real life, when we write these glorious plans, we never really get to build. It's a really long-term chronic thing. I mean, if you got a really diabetic, it's an ongoing thing. They'll probably bring that care plan looking everywhere they go because it's a big problem. And that would be maybe the only thing, well, like going focal focal and diabetes work together very well.
Well, that's what I was gonna say.
It's
Diabetes
usually
is one
you don't
thing,
want
but
a
sleeping
medical
pattern, how do you improve the
diagnosis.
sleeping pattern, you know?
Yeah, but I mean, we usually don't want the focal to be a nursing, we want it to be the nursing assessment, not the disease. Remember that first page? I mean, that first PowerPoint where it's talking what medicine is, what nursing is, and then we're collaborative by using different modalities to improve our patient care. All right? Okay? Sure. Oh, you can put diabetes. Didn't you see she had it there? Well, I mean, you know, or COPD. I mean, it wouldn't be in this predicament, but it's what about that diagnosis? Like high glucose, we already know what that does. Doesn't help. So this, you would tie diabetes with skin integrity, blindness, I mean, it's just really a huge problem. Okay. Renee. Oh, that is, in fact, even Cynthia said,
Got the girl's name right.
remember all his names.
Got the girl's
Oh.
name right.
I'm out there.
I was just gonna ask you, can you repeat what the mode is?
Oh, sure. See, it's pretty clear in a PowerPoint. The mode is how you're looking at the patient's what colored lenses. So our job is to look physiologically. If you look at your syllabus, every one of those things that are listed in ROI for areas to diagnose or problematic is related to modes, physiological mode. All right, then the second layer of care that we can give is psychosocial. All right, or one of her theories is the biopsychosocial adaptation of my patient. So if we take care of the biological problems, then we go into the psych problems. So self-concept. We have a chapter in your fundamental book about self-concept. It doesn't hurt to look through that. I don't believe it's on the assignment as much. We should talk about self-concept so much with Roy in 105, but it's a good chapter to kind of help you with your patient thinking. What kind of concept do they have about themselves? The other modality, role. Okay, you've just had a patient be admitted after a catastrophic accident, and he has lost, what, 1 or 2 limbs? His role is going to be different. Okay, you're going to be looking at the primary, secondary roles, you know, age. Some things in role we can't change, like modifiable risk factors versus unmodifiable, so it would be like that. And then the fourth one, so we've got what? Let's take it up from the top. Physical, psychosocial, which has how many? We haven't finished it. It's self-concept, role, and then interdependence. How are they relating to their environment? Is there a dependency? Is there anybody in the family that can help? Which ties very closely to role. So sometimes, in the old days, we used to ask for a care plan with all 4 modes, and it was just too much. You guys were like, it's too much. You've got too much to do. I'm not one of these people that wants you staying up all night long, making drug cards and doing care plans. You know, and that's kind of the way it was there for a while. You know, it's a little nicer for you guys in that respect, because most nursing schools have backed off that insanity plus. I had so much work when I was in this, yes, that we don't even give. I don't know why, it's just it's a culture that we could change. Yeah.
But in practice, when you're helping the family, you are going to have, be careful you want to do all of it.
Well, they'll be identifying what's wrong with this patient, and if they've got a chronic disease, they already have made those nursing care plans, and if you're an electronic chart, it just keeps going. So you wouldn't be dealing with nursing diagnosis, you might add to it. You know, like you assess something like nobody thought, okay, this is probably the day, has anybody done this? Then you would contribute by giving that assessment intervention or a student care plan. Okay, it's hard for you, like, it'll be very difficult for 3/4 of you because you don't have access to all the computer pages. There's, you know, unless your instructor lets you in.
But they always tell me that there's a logical reason with that.
Well, what do you think what do you think about a psych hospital?
Okay.
It's like, you know, at the grocery store, you can shop for whatever, you know, at any hour. And it changes. You know what I mean?
For the goals, you need both the long-term and short-term, or just one or the other?
Well, there's a lot of discussion about that. For you guys, just first go around, just do a short term. Now, let's just get through the first 4 days of nursing school. It's you and me, so I get it. And there's too much to kind of categorize it. And you're like, what next? You're on a mobile, sitting down, and landing 4 bumps. So I have a couple of these that, I don't know, I read this to you. Some of us will just have you do just the, this kind of a sheet. Not all of us have that, but just don't get married to anything except for the one that we have that's pages long, and I'll talk to the faculty in the meeting because I don't like giving you Insanity Plus. I like this one, all 104, but I don't want you confused. So they always say, we'll start with the big one that's pages long, but you don't have to fill it all in. But it's important for you to get the conceptual idea of validating what you're assessing. And since you have a clear slate, you don't know what's what, we want you to learn how to critically think about these diagnoses. Now, do you feel a little bit better about this care plan?
Yeah.
What I would do is go back and go through that little book. And yeah, that one. I lent mine to a student. I didn't have it. And I'm being cheesy. I didn't want to spend $20 when I taught you something. $20 for that. And I was like, maybe it'll come back to me. You know what I mean? But it is your Bible for Roy. Because you need to read that book. Some of you bought it, and if you did buy it, you'll see that I've taken excerpts out of that in some of my PowerPoints. But it's a lot of language. But if you just think about what it means, like residual, has that ever been in your vocabulary before? Yeah. See, that's the hard part. You have so many terms, but this is like the easiest one I can present first. And this is the only time we can make this for. Unless you want to do this little stuff in clinical for your teacher, your clinical instructor. This is like point. You can get this done in like 10 minutes once you get good. And these are extra things that it doesn't have in it. Because we used to hand them out, and now this is used all the time. So let us, I'm going to show you out, I probably have that uploaded. You know, like just separating it out. Like here's a nursing diagnosis. Ineffective airway clearance related to excessive secretions and ineffective cognitive outcome or goal. Patient will have improved airway clearance as evidenced by effective coughing and patent airway. And that's all it is. And they're going to tell me, how am I going to reach that? It's, you know, all those things that are in these books. So you look up this is dialed diagnosis. Here, this is like type 2 to read it better, my students. So the first couple of pages in here are talking about care plan. Very simple. You know, I settled on this one because it's in your pocket, so to speak. But I mean, it can go on and on and on. But it's nursing process. There's a little spiel in the beginning about assessing diagnosis, So when you actually give yourself, like, check this out when you get, and then there's a guide. This is a lot shorter and sweeter than it used to be. So. And then you've got a book full of diagnoses of what to do about it. I can always tell when they come from the book, but I don't care. I want you to just learn this and you guys have it. So here's one. Oh, I don't know that one. That's sad. Well, yeah. We'll have death and dying as part of it. Yeah. I think I'm going to be uploading that. And then I have another one of an adolescent who is not eating. Oh, it's in your PowerPoint, but it's probably too small. So I'll just upload that. But, oh yeah, you need more information. And if that YouTube thing is good, look at it. But I'll give you the link. So, and it even gives you a lot of vocabulary in here. Like sometimes when you first go to the clinical the very first day, you're going to say, what language were they talking? And I mean, it's like, and they don't care that you don't know. So just stand up and put your ears, if you can catch it and write it down even phonetically, that's great. That's a start. I usually, some of the particular hospital I'm at has a S-bar with everything under the sun in that one piece of paper. And it's all in abbreviation. And so the very first day, what I had my students do, circle everything you didn't know or whatever. It's completely circled. That's okay. All right? That's okay. You get better, you understand, and then once you start getting comfortable being that nurse in that unit, you'll be able to bond with different nurses. Some are excellent, some aren't, but you don't take it to heart. Yeah. Just like when you guys rate my professor. I don't even look. I gave that up a long time ago. I get like, oh, another cursory knife wound. No, I have friends that do that all the time. Oh, it's not good for the ego. Yes, you got a question? Oh, wait, I gotta give her book back. I've been known to do that. Okay.
So going back to the mode of time.
Oh, look at you guys, we did this? Wow. Oh, is it that big? Which one? It's the same thing, but it's just on 2 pages. I guess we could. But I have one that is in a file that can keep going long and longer. So, anyway, that's fine. Go ahead.
So, going back to the mode, in the book there is a case of a patient who has had how's it called, a prostatectomy.
Oh, good.
So he has lost, there is a possibility that he has lost, the nerves for erections and stuff.
Depending on, yeah, then that going to be covering that.
So my approach to that patient would be physiological or raw, because now he's kind of.
See, he's already going there. What? Yeah, I mean, it's all of that. It's all of that. But as nurses with more information and more education, I would probably have both of those diagnoses for him, plus a couple other, So yeah, it's just that we want you to get comfortable with the physiological mode. And I've had students just can't deal with the physiological. They went straight to roll, and that's fine. You're thinking that way. That's wonderful. But at this point, we just want people to focus on what's wrong physiological. And let me tell you, older adults, when I give that lecture, I'm going to be like one. I mean, wow, how many meds they take? It's just like sadness. So, and one of the other things I wanted to share with you is you all learn differently. Some of you are doers, some of you can listen, some of you are missing this PowerPoint because you're visual. So whatever technique that you learn from, you got to tap into that and, help work in teams, because every person that, I always work in, I highly recommend that you study NCLEX questions in groups, because it's like your perspective might be different from your perspective. And like I was saying, the reasons why they're not correct are just as important as the one that is correct, or the multiples that are correct. So I'm not doing it, select all those, apply for a while, because that just overwhelms you, or prioritizing. Oh, I hate them myself. Even when it says wash your hands. I'm looking at this thing and I'm like, I can see where something like that too, and then this one, great, but maybe, you know. It's all in the wording of the test, it's all in the way you're interpreting. And one of the things I do have to share with you is you do not read into these questions. Don't bring your clinical experience in and you're saying, okay, there's some absolutes that you must follow, and there's certain words that tell you which one's the answer. You just have to kind of, you know, work together and look at what is the purpose of this question, what are the STEM vocabulary, and which one of those answers answers that question. Okay, I gotta change venues now, because we're running late. Yes?
Really quick. I'm sure I'm not alone. In the lab, we noticed that videos and the presentation is what do you guys actually?
Oh, you mean the difference between the videos and the book? You always want to stick with the book. Okay? And you're not really tested so much in one grip, maybe occasional quizzes. There's no like exams or it's always about clinical skills. And the reason why we haven't gotten that completely organized is now they want us to do quizzes, and we haven't had quizzes in our skills in a long time. So we're kind of going backwards. Like it used to be a huge course for 1 year. We got to, chill it out a little bit. But we got to get your vocabulary, and I think it's going to be like about quizzes about vocabulary or key terms. Metric math will be coming out because you have to pass a math test before you're getting meds. So, is that something? Yeah, you're kind of in the dark with 115. I'm working diligently. I'm so excited that I'm working
Somebody said me too.
Like as soon as I wake up, I'm just like, I'll walk my dog and like get nice and I gotta read forever. And I don't get it.
Washing eyes? The rusty one or?
No, the video said white for inside.
We till break. What time do we break?
So that is
I say like 20 minutes. 10 20
You're going to
minutes.
have to show me where it says that. Okay. Because I certainly know that that's not what you do.
perfect. So that's why
Work this way,
inside or out.
Not even which is great, like a dog.
Okay.
You'll have to show me that, because that's wrong. I'll write the edit. Okay, I don't remember that. Anyway, follow, well, that's one of the reasons. But then you saw the discrepancy on cleaning.
Yeah.
I mean, I like to think that I have common sense, standards of practice, what works for the patient.
Yeah.
And like for me, I've had to do a lot of things very quickly on a screening meeting that's like 10 months old. And you just gotta do what you do. I actually had a stethoscope with a counter on it. And I've been like, these kids are like, very helpful. So, shall we take a break?
Yeah.
I'd like to call Sam and see if he can. There's this puppy. So, maybe you're doing more care.
You're gonna get your snack.
1 page, not exotic.
Okay. You're gonna go to vending?
Feel like you know the words, right?
No.
You don't.
That's the vending machine. Right. So. No. Yeah. I'm gonna do something else. You're gonna stay here? Okay. I think it's that. I gotta make it.
I
gotta make a phone call real quick though. What? I gotta make a phone call. Give it to me. Are you gonna go to dosage again? I have to make a phone
I know. What paper? Where is it? I don't see it.
I want to make a copy.
Oh yeah, me too.
Let's make a copy.
Oh, that's what I was worried about. I guess
It's not the same. It's the same, but it's different.
Did you make a copy?
I did.
Oh, okay. Yeah, it's good.
And then, you know, if that told you was scanning anything, then it's going to say, do you not have this drug? And then you'll double check. And if you do have it, then you'll hit no. If you don't have it, then you'll hit yes. But if there's any errors, then I'll take care of it later. Like, just let me know. But, yeah, only hit no if you don't have it. But so make sure that, hit no if you don't have it. So make sure you do have it. So you just have to be careful to make sure you scan everything so that doesn't pop up. Like what I do is I scan it and I put it in a different tote, like an empty tote or something. Yeah, like that's usually it's asking how many medications you got in, and it should say shortage or overage. If it says 0 and 0, then you confirm. But if it's saying you're short something or you're over something, and you actually had everything correct, then don't confirm. Does that make sense? The fluconazole, you just scanned it, and it popped up, and you do have it, so you're gonna hit no, and then that second screen that pops up, whatever it said, what did it say again?
I took a picture and I did it, but that was
But does it say to hit yes or no?
I think so. Okay, so they have to stop during the
Oh yes, so if we really did receive 3, and we're supposed to have 3, then yes, you'll hit yes. Yeah, and again, just have Brenda cover the front for you because you have to do this within a time limit, otherwise it's going to close up. Oh yeah. Okay, and then if Mosaic is there, just call him and say, you know, there might have been we had a tote audit this morning and there might have been some discrepancies, so, but there wasn't, so can you double check our invoices, because that's a 3-way check, okay? So just tell him that there might have been some discrepancies because you accidentally hit yes when it should have been no, so you want him to double check the 3-way, just tell him the 3-way check and he'll know what you're talking about. Okay? Alright, I'm going back to yours now. Goodbye. Oh, I'm so sorry. My job can't function without me.
I knew it because I had it. It was one thing I knew that.
Oh, so where? When you give them a hold of my hand.
After you buy the Hesse thing,
Yeah, I do.
then yes, you'll have to go get the code from her. I'm so sorry.
You know, I'm like, oh my God.
On my care plan, I'm going to put, I have incompetent coworkers.
No, you know more than I do. At least you know, okay, like if it was, I would be like,
Patient seems stressed, incompetent
and I'm like a really long thinker. I'm not just like,
Huh?
How long do you work?
even though I
Well, I used to work like 50 hours a week because, again, incompetent coworkers. And so I have to go back and basically fix everything. Like, because I work in a pharmacy, so everything has to be on regulation. My staff can't stay regulated. So if the Board of Pharmacy comes in, we can get fined, like big time. And so every day that I come in, it's cleanup, make sure everything's on regulation, everything is filed, make sure all of our C2s are posted,
even like, you know,
like returns are done. All inventory things is me, and then all patient complaints is me. And anything a pharmacy manager will do, he pawns it off to me until I can't handle it. So they're like, now I only work about 3 to 4 days a week, and I get phone calls like that all day long. How do you do this? How do you do this? Where is this at? It's all organized, damn it. That's the type of job I have.
So you go from here to being stressed at work.
Huh?
So you go from here to being stressed at work.
Yeah, this is easy compared to my stress at work.
I'm really sorry. I have to like for this class, we actually needed, you know, they have to reset employees.
Did you buy the book?
No, I haven't. I mean, I have to read it. And then I have to
like the one over step.
Yeah. Facebook, I wish I did it, but I can't. The farm.
She gave it to me, so I'm gonna have to check
Yeah. I try to get as many. I couldn't find this one yet, and then I just after I was like, this is like. So you got the whole thing. I was like, damn it.
Yeah, like you read it and you take your own notes. That's how I do it.
I'm sure I did. I even read it too? I thought I did.
You don't need to post it.
Was that trying to email about the names of
Yeah.
I thought I needed to book.
They came with the code.
Wait, it was in here though, right?
I have the book. I didn't get it.
It's probably in my bundle.
I was doing that for every chapter. That was
I don't know, I just grabbed it out of my book. Yeah, no, I haven't even looked yet. Alright. Oh, wait,
yeah, I just have one that she went over tomorrow. And I have her. I read it. I didn't read it. It's just that, you know, with all the laws, all the questions and actually at the end they ask you too, which law is that, this is whatever, and I'm like, wow.
I did get your text. So we together
Or you log on to
I record the lectures because when I listen, I get it in first, I get as much as I can. But I like the visual. But then when sometimes I miss one or two things, and I like to be able to go back and look. And then I know that's when I take notes, the lecture I'm like, I don't get that. Let me make sure I So yeah, I'm like, okay, but some of this it's like, okay, I know this all my previous classes. Because I did biochemistry, like the math, that's what I do. All that. That's why I'm like, when I got 1, 2, 3, 4, 6, 8, 12 and 16. Like I don't have to think about it, you know? And people are trying to teach me.
Oh yeah, LA.
The long one.
No problem.
So I'm like, okay, let me just give me the problem. No, but like, I can break it down.
Right.
But a lot of times, they're all in step 1, and step 4, step 5. If I'm teaching somebody else, I can break it down. But some things, it's
I already have one for pharmacology.
I can't get
Yeah, I don't know. I do. I have it on my phone. There you go. I hope I have it.
And she goes like this. Well, I know like
Oh yeah, they do give you.
the whole bag.
majority is.
Okay.
So I'm trying to release here today.
Brian, you can't change Brian or Jonathan. Sorry, Jonathan. You can't change the settings to that, so it's not like it's still private, but not private to where you can.
Thank you so much for helping me.
That's weird because like yesterday I was able to find it at least.
Some people can find it, some people can't.
That's weird.
You added it.
Yeah, that's why I was like I was able to find it, but.
I just added myself, and now I'll add it.
Where is it?
Johnson? Yeah, the last name's Johnson, like, Johnson.
It's not even really cold, but I like it Oh my god. But it's good because you get Oh, I would love to.
Did you serve it? I'm sorry. Eat a little bit right now. Oh, sorry, I didn't mean to interrupt. I apologize for my fucking breath now, okay? Wow, I don't care. I'm just saying, I'm gonna be like, ooh, what'd you get? Just a taco from El Pollo Loco, but the onions are like so potent. I don't smell anything. I was telling Shannon that my breath is stinking. Beware. Beware. Do I keep this or do we pass it? I would love to just pass it. Let me take a picture of it. Okay. 3 times in a row? I don't know. I took a picture of it.
I did too.
Sorry that
You should take a picture of it. I'll just get your picture.
I'm not. I'm usually the one
Now you got your appetite wet.
person, but right now I'm
What? You got your beak wet.
I'm trying to be, but let me tell you, this is not in order because this is not on like the next thing. It's supposed to be in order. It's not in order. I don't know where she's at. So you guys just bought the, but we're not.
You guys bought the.
You just bought it to have it. Like all of that.
Oh, I always eat. I'm always eating.
How will we know? right now. We get done now. They're trying to. I left around 5 2 hours in the library.
Maybe like 4:45, because I got home like around 5.
Yeah, I got home.
Everything. She's children was like, she's
I know 105. 104?
what she would like, it did double payment. She couldn't, there was no thing
Like, take the damn code already. Like, you know, you're paying for this.
So that's Eastern time. So what we can finish like 4 10. So you don't want to